In today's video, we're going to be talking about racial disparities in healthcare, particularly amongst the Black community. This is a true problem in the United States right now, and in order to really tackle that head on and try to start fixing this, I think it's so important that we educate ourselves, look back at the history of some of this inequality in healthcare, take a peek at what is happening today so that we can move forward with the goal of taking that education and acting on it so that we can eliminate that disparity in healthcare altogether. If you're new here, welcome. I'm Liz. I'm a family nurse practitioner and I work in primary care family medicine. And before we dive into the main content of the video, there's just a few things that I wanted to share. One being, this is not the video that I had dreamed of being able to make on this topic because we aren't taught this in school. I don't know, maybe you are, but I feel like my entire education on this was literally like, yep, there are racial inequalities. Maybe here's like 2 facts, move on. Prior to college and grad school, I certainly wasn't taught then either. So I quickly realized over the past few days that this is something that's going to take a really long time to educate myself on because I'm missing like literally half of history. So this isn't going to be a history dense video that I had hoped to provide you with. We'll go over a brief overview and hopefully one day in the future I can make a video like that. But I just kind of wanted to throw that out there that this, I had hoped for one thing, but I think hopefully this will provide you with at least some value. The more I dove into the rabbit hole, the more I realized the rabbit hole is enormous. The next being, this is obviously not something that I have lived with my whole life. I'm white. I have grown up in a very privileged aspect in that way. So the things I speak on, they're not going to be perfect because this week has been a huge learning curve for me. I fully admit that I did not take the time to learn about this like I should have before, and I can't change that. All I can do is acknowledge that that was a failure on my part, and I can do better in the future. I can learn about this, I can continue to learn about it and have dialogues about it and try to just become a better provider for my patients. So with that, if I say something that's wrong, I apologize, and by all means, please let me know. I would love to have any feedback from any of you at any point during this conversation in the comments, especially if you've lived this your entire lives. I recognize that that's exhausting, so I don't want you to. If you're in a place where that's outside of anything, you're just tired, please don't. But if that is something that you would like to give input on, I would love that. I will be watching the comment section of this video very closely, and there will be no negativity. So if you are energized, but you want to spend it in a negative way, there's lots of other places you can send that. This will not be one of them. And then the last thing to address, because I know this will come up, I did leave the monetization on this video. I will be donating all the proceeds from this video, which individual, it's not a lot. So I will be doing all of it from this video and then a portion from all of my videos from the last month to some organizations that I will leave linked in the description below if you would also like to contribute in any way. I'm just gonna, I think, spread it over, there's 4 or 5 of them, and like spread it between the 4 or 5 of them. And I think that's all the ground rules is 1, we're just educating ourselves, hopefully taking that into practice. 2, please, any feedback is very welcomed as long as it is constructive. And 3, there will be resources. Oh, also other resources below. Anything I talk about in this video, as well as just other resources, things where I've gotten my information from will be down there, and other just like places you can check out, like books to read to educate yourself, Netflix shows, a podcast that I've really enjoyed diving into. That will all be linked down below. But first, let's address some very simple ground rules here of things that I've come to understand, particularly in the last week. 1, terminology I'll be using in this video. I have had a lot of interesting discussions, especially in the last 48 hours over on Instagram, about when you're using terminology Black versus African American and which one is more appropriate. African American in its context denotes origins from Africa. And a lot of people have commented and responded and said like, that doesn't apply to me because I'm from Haiti or Jamaica. And they were like, and I identify as Black, which seems to be a much more inclusive term. However, on the flip side, I've also had many other people say, when you refer to me as a Black person, that makes me offended. So I think this is something that is going to be very individualized. And we'll talk a little bit more at the end of the video about how I'm planning on incorporating that into a practice change in my future and how maybe some ideas for you as well. But for the sake of this video, I think I will just use the term Black population, and I in no way mean any offense by that, but that's kind of where I'm coming from in terms of using that terminology. The second being that this is obviously a very multifactorial problem. Racism is so inherently ingrained in the United States and probably in many areas of the world that all of this, it's not one single source. So through diving through this, it's not, I feel like the more I dive into it, I'm like, oh, this is in my mind, my very naive mind. I was like, oh, we're going to go and dive into history and find like X, Y, and Z points, which leads to the situation of today. And that's just not the case. It is so ingrained in so many different aspects of life that it's become systemic. And we won't be discussing all of the system today, but that's why I kind of wanted to bring a little bit of the healthcare aspect into it, because it certainly plays into the whole situation. And as I've said before, I think the key to all of this is just understanding where we've been so that we can kind of get a grasp on where we are now and where we don't want to go in the future. So I highly encourage you to utilize those resources I linked below and get plugged in on Instagram. And there's so many great accounts that are going around right now, and I will leave some of those linked down below. People who are just willing to share their experience, and just browse the comment section in case anyone has also chosen to share their experience down there. Listening is how we're going to learn here. Also, something I think is important to say here, man, I'm so sorry. I keep saying like, we're going to dive into it, and then I have other things. I keep thinking of them. Something else I think that's really important here is I feel like many people might be like me, in the sense that I was always like, oh, I don't see color. You know, I'm not racist. I don't see color. Like, it doesn't matter to me. And over the last several days, it's become wildly apparent that that is certainly not enough. That one, it's like, you should see color. You know what I mean? That influences so much. It's actually helpful to see it, acknowledge it, and work with that person. Like, it's something that everyone should be proud of. And it influences so much of life that to not see it is just ignorant. And I recognize that now. And two, it is not enough to just not be actively awful to people. A common term I've heard is like anti-racist. So for an applicable example, it's not helpful at all if you're sitting in the break room and everyone is talking about Megan, who's a Black nurse that works on your unit, and says something like that's racist, and you just don't say anything. That's being complicit. It is actually, you have to actually say something, which is uncomfortable, and we're gonna have to get uncomfortable to fix this, because it is so systemic and ingrained in everything that it's going to be uncomfortable. So I think going forward, I would encourage you to do that too. Have those uncomfortable conversations. You're not going to be popular. I have already become unpopular this week with several people, and it is uncomfortable. But that's another opportunity to kind of self-reflect and realize you are making the choice. You have the option to become uncomfortable rather than just being born in a situation where you have to be uncomfortable every single day because you happen to have more melanin than me. I think we're actually ready to dive into the history of this now. Let us try. One of the things that I hear very, very often from my patients, and I've heard this from a lot of other people, is we'll have a Black patient come to the office and say, I don't trust doctors, or you'll hear like, why, how didn't they go to their healthcare provider? Like, they are so far down the road. And the often answer is, I don't trust healthcare systems or my healthcare providers. I don't trust doctors. I don't trust nurses. I don't trust the healthcare system. And let's maybe look at why. We will not be going like deep into the history of all of this because we really don't need to drive the point home. There is certainly a great deal more history, but like I said, the last 100 years, we've really knocked it out of the park in terms of how terrible we can be. 1946, this is just after World War II. This country was undergoing a lot of change, and it was decided that this country needs a little bit more healthcare infrastructure. You know, healthcare was very different back then. It was a lot of people going to each other's houses. There were not a lot of hospitals. It was not as nearly as widespread, and people recognized that we should probably, implement more of a healthcare system. So the Hospital Survey and Construction Act was passed. This gave out annual funds from the government in order to improve, just staff a healthcare system, try to construct a healthcare system essentially. But the way the money was distributed was it was up to the states. So the federal government gave the money to the states and then gave the states the power to divvy up the money based on perceived need and how many people lived in the areas. So like saying like, hey, please distribute this evenly amongst your population, obviously build more where more people live and, make sure it's all even. And you can probably imagine how that went, particularly in the South, in which racism was still wildly rampant. In the North too, but like the South kind of a mess. The NAACP very quickly realized like, this is not going to work out very well for many Black Americans, because the people who are in charge of divvying it up are probably not looking out for many of the Black Americans, because most of the people in charge were white, and you couldn't even get on the board of the people who were trying to get in because that was either illegal or they wouldn't let you in because you have to be voted into a lot of those situations. And that in itself is a struggle that we still see to this day. But the NAACP went to the federal government and they said, I don't see this going well. And the federal government said, oh, okay, you're probably right. Let's meet in the middle and they landed on separate but equal. So you can distribute the funds and they do have to be equal, but you don't have to be in the same buildings. So you don't have to have the same healthcare systems. You just have to allot them equally. But that was how much oversight they gave it. There was nothing further other than that, and you can imagine how that went. And then over the next 20 years, this just kind of cascaded out into an immense segregation in the healthcare system. So there was hospitals for white people, and there were hospitals for black people. And if they were incorporated in the same building, you know, sometimes it was like in the basement was the ward where if you were black that you could go, or over on like some other building that was right next door. Incredibly underfunded, did not have enough providers. People were dying because they just didn't have the adequate access to healthcare. And even receiving care at one of these hospitals was based on if you could afford it, because Medicare didn't exist. So there was no state-funded healthcare system in place yet. So the entire system that our healthcare system is based on started in a very segregated way. And if you're sitting there and you're like, oh, that was like still a really long time ago, I thought we'd kind of talk about it in terms of my family. I'm 30. I'm sure some of you were 30. If my family was black, my grandparents, they would have lived the first like 30 years of their life having to go to the subpar healthcare system because it was underfunded, it was in basements, it was overcrowded. We get it. Let's jump forward a little bit. 1964. Title IV of the Civil Rights Act threatened to withhold federal funding from these hospitals that practice segregation. This was really difficult to enforce until 1965, the next year, when they rolled out Medicare for the first time. When Medicare was implemented in 1965, this gave access to many, many more people who then the government could say, if you don't let them into the hospital, your funding will be pulled. And this did assist in integrating. This took in a lot of places a couple more years. But to give you some context here, my parents were both alive by 1965. They were a couple years into being alive. My parents could have still been born in a segregated hospital. My mom received a surgery that saved her life when she was young. That could have been done in a segregated hospital, which might not have gone quite as well if we were black, just to give you some context up there. So that's kind of going backwards and looking at how our healthcare system was set up, how long the segregation lasted until the 60s, when most of our parents were alive. Also, I know everyone's not 30. Some of you may very well remember this actually being a thing. For the sake of this argument, I was just pretending everyone was 30. So that kind of covers the segregation that we've seen until very recent history in this country and how everything was set up. Now, in addition to the segregation, let's look at some other things that have likely impacted the statement, I don't trust my healthcare provider. The Tuskegee experiments. You may have heard of them. If not, I will leave a link down below that gives you more information. And this was a study where some researchers essentially gathered some black men together and said, let's see what happens if people live with syphilis for a really long time. What are the long-term effects of it? Now, the study has many, many problems with it, but the biggest ones were the study started in 1932. It ended in 1972. Okay, that's a very long longitudinal study. Problem here is penicillin was found to be the cure for syphilis in 1945. But they didn't get the cure because they just wanted to see what would keep happening. The study ended when people found out about it, and everyone was kind of like, wait, what? And then it ended. So it wasn't like it ended eventually when people were like, oh, this is probably bad. It ended because other people found out that, oh, you have had the cure for this horrible disease that causes horrible death, all types of awful neurodegenerative things, skin things. And we just watched for like 30 years while you knew about a cure. And that happened well into the lives of many of our parents, perhaps you. That doesn't plant a great seed of trust within the healthcare system that was already fairly segregated to begin with. Other examples of this would be like Henrietta Lacks. If you have not read The Immortal Life of Henrietta Lacks, I highly recommend it. That was a great book. She had cervical cancer. Her cells were taken, and they've been used as a culture medium. So that's like things we grow other cells in for until like now, HeLa cells. But she never gave permission for that. So it's kind of just taken, used, and it's now made, like a lot, scientists use it everywhere. So one, not only has it been profitable, but two, no one asked. And in case it's not very clear, it's very important in healthcare to always ask permission before, doing something with someone else's body parts. Even if they're cells, that doesn't really matter. It's the principle of the whole thing. There are many other examples, but like I said, I just didn't have the time to kind of dive into all of them. Maybe one day, hopefully one day. There was a book I found called Medical Apartheid by Harriet Washington, and she goes into the history of discrimination in healthcare in the United States, and I will leave that down below. I'm going to go on my reading list, so I'll share what I kind of learned along the way as I'm going through there. But all of that kind of has come together to, one, give a mistrust, and two, there are fewer Black Americans who are willing to enroll in studies, not shockingly, because of all this. So there's less research, which obviously probably does not lead to better outcomes. Now, that's kind of a brief, not so brief history. Let's talk about some current healthcare disparities if you're comparing Black Americans to white Americans. In the United States today, if you are Black, you have a higher rate of the following when compared to your white counterparts: high blood pressure, diabetes, stroke, inability to find a healthcare provider due to cost, and obesity. You're also much less likely to have your pain taken seriously in both acute and chronic events. Black individuals who are aged 18 to 49 are twice as likely to die of heart disease. And those who identify as Black are more likely to die at all ages of all causes. All ages of all causes. Looking at some primary care stuff, studies are showing us that Black Americans are typically offered about 1/3 less preventative healthcare screening, so cervical cancer screening, mammograms, colonoscopies, than their white counterparts. And that is if they're even able to get into a healthcare provider's office to be seen in the first place, which we know they're already not getting in to be seen as much, as we just learned. Let's talk about pediatrics and women's health, because this is truly frightening. Infant mortality is more than twice as common if you're comparing Black babies to white babies. Maternal mortality is higher, but if we're just looking at patients 30 and older, it's 4 to 5 times higher. Those two statistics, those like really get me, because I just had a baby 9 months ago. I also had one 2 years ago. And I can tell you that I was not afraid going into the hospital. Like I was afraid, like, oh, I might hemorrhage, I might have this, like normal things to be afraid of. But I was not worried of going in and having a baby. Like my race did not even cross my mind. And I have talked to many people since then who they said, I was worried going in knowing that, because I might not get equal care. And that you're already in such a fragile, vulnerable state of your life. Mama Dr. Jones has a great video that talks a lot more about this specifically. I highly recommend you go watch it. I will leave it linked down below, but that is unacceptable. And one more thing tied into here, people in the Black community are more likely to have infertility, but it is much less likely to be addressed. I can tell you a story from my personal life. I have PCOS. I have a friend who also has PCOS. I'm white, she's Black. We both went into have the same conversation around the same time, and and we wanted to have babies. She is like way more in shape than me, and just like way more. And we both went in, and I said, hey, I have this, like I don't get periods regularly, so like I'm worried about ovulating. What's our game plan here? And she said, oh, like if you don't get pregnant in 3 months, here's our treatment plan. Friend goes in, same conversation, same exact symptoms. And she was told to lose weight. I don't think either of us needed to lose weight. And if we were comparing, I needed to lose weight more than her. So that's just a personal example from that. I've also heard that from countless patients. A lot of people don't even think to bring it up because they feel like they're going to be dismissed because going into that. So those are just some of the healthcare disparities that we see in our country today. Like I said, I will leave data on that down below if you want to go check it out. So that appears bleak. Those are not great numbers and comparisons. Looking at why, I think it's so, like we talked about earlier, so multifactorial. Less access to care, not the same care, not being offered the right care, a chronic level of stress just from dealing with racism every single day of your life, different education backgrounds, different opportunities, different, just being treated and seen different. They all commingle together and have produced this. And that's why we're here, is to learn about it and try to understand it more so we can fix it in the future. And so I just want to kind of translate that really quick into something maybe like that we can actually do moving forward so that it doesn't have to be this awful forever. So while I'm certainly not an expert on this, I wanted to leave this video off on some tangible things that maybe you could do in your practice and hopefully bridge some of those gaps and make people feel more comfortable to come and get healthcare and increase access to healthcare so that we can minimize some of those truly frightening gaps. First one is just listen. Just that, it is that simple. I feel like so often I've had people tell me that they just feel very unheard. Just listen and like really absorb it. Don't blow it off. Truly listen. Listen to your patients, get to know them, and really ask. Something that I have found helpful to sometimes add at the end of my appointments is just like, is there anything else you would like me to know about you? That has been helpful. And another method that I have found helpful is sometimes asking. Sometimes patients will decline something or they seem really resistant to it. And in a kind way, sometimes I've said like, would you mind explaining to me like why? Trying to understand why. And often that has led to some interesting conversations that are like very enlightening about how people just feel scared and that, they are mistrustful of the healthcare system. So really just listen, try to understand why. And if you have anything, like I said in this whole thing, if you have lived this and you want to add anything, please do down below, because this is where I feel like I don't have a ton of experience. The second thing would be having conversations about terminology, like we had talked about. Ask your patients, how do you identify racially? You could even leave it on your intake form. You might not have power over where it could just say like race and then blank, and then that would allow them the opportunity to say, this is how I identify, not just Black, African American. This could apply to any race or ethnicity, and allow people the opportunity to tell you how they would like to be identified, much like we've started moving into, like what pronoun would you prefer? We're not very good at the race and ethnicity part quite yet. So I think when race does come up in your conversations, for example, if you're going to prescribe a blood pressure medicine and you're going to have that conversation, I'll be honest, I didn't know how to say it because I didn't want to offend people. I didn't want to say the wrong thing. I think going forward, I will just have that conversation and say, our treatment here is going to be slightly guided by your ethnic background. How would you racially identify? That I think is going to be my stance moving forward. If you have a better idea, I would love to hear it down below. You don't always have to have those conversations, but sometimes you do. I prescribe a lot of blood pressure medicine, so I have that conversation a lot. So that is something I'm going to implement moving forward. And it puts the ball in people's court so they can actually decide, because I don't get to decide because it's not me. Another interesting point along with that kind of brings up, and this is kind of just like a thing to consider, is research almost always uses the term African American. I was always taught in school, like all the textbooks are always like African American. But if you look at that term, that's people who originally came from Africa. One, that term kind of in itself implies that you're not American. A lot of people who were brought over and were slaves who are African American were here far longer than my family, and people just call me American. So inherently that's kind of racist. But either way, like in the literature, we call it African American, when ethnically that's very different from people who are Haitian or Jamaican. But we don't really differentiate between that. So that's something going forward that I think would be great if we could integrate that into like education and research of, do we even know if these medications that we're prescribing you, when we look in the research and we say, oh, you're Black, so I'm going to give you this instead of this for blood pressure. But was the study, when you go back and look at the study, it just says African American and it doesn't break it down. Are you talking about Black people? Are you talking about African American ethnically? So that's something to think about going forward. Topics to bring up. If you are the future of our research, think about it. And then lastly, going forward and trying to be a voice for change even when you're unpopular. Like we talked about before, the confrontations I have had with people in the last week have been uncomfortable, because it's never comfortable to call someone out and say like, ooh, like, I'm not going to let you talk about my friend that way. But I encourage you to have those conversations. And I encourage you, if you're going forward too, in a form of correcting people, because I've been corrected many times in the last week. One, be open. If you're the person being corrected, try to be open to it. Like I said, been corrected more in the last week than I have ever been corrected in my life. But I'm just trying to accept it from a point of like other people are trying to educate you. Anyway, those are my thoughts on that. I think this turned out very long, and I apologize if you're still here. I appreciate you. Like I said, I don't think I'm certainly not the expert on this. I have a lot to learn. I will be linking down those resources of things that Joe and I plan on diving into to like further educate ourselves. I hope that we will really see some change come out of all of this, because I think a lot more people have listened, me included, like really listened, and taken a second to, when corrected, not say, but I, because I know I fell in that camp. I was like, but I, and just say, okay, like, you're right. You have a really good point. Internalize it, learn from it and move forward. And I hope that many of us can do that, and that we can start to eliminate some of these disparities that we see in healthcare, because they're not okay. I so appreciate any of you who have chosen to dialogue in the discussion below. I think this has just been a really good time to learn from each other. But also, again, if you do not have that energy to dialogue, that is a-okay. And I hope you never feel pressured to, because I know it's just exhausting to live with this. That's a constant stress, which also leads into all of this. It's just the stress of that's an added stress that people have lived with for their entire lives. And we know stress does horrible, horrible things for your health. But thank you for being here. Thank you for listening. Thank you for educating me. And I will see you in the comment section. Bye, guys.